All right, team, welcome. We are diving straight into a high-yield masterclass on cardiac mass imaging. No time to waste, let's get right to it.
First up, Section 1, the Imaging Blitz. This is your rapid-fire briefing. We're moving fast, so keep up. The mission is to identify these cardiac intruders. Let's move.
Echocardiography is your first line of attack. You're looking for pedunculated masses, think myxoma, or multiple masses, think rhabdomyoma. Got it? Next.
Cardiac MRI. This is the gold standard for tissue characterization. It's going to show you the invasive nature of something nasty like an angiosarcoma, especially with late gadolinium enhancement.
Cardiac CT, what's it for? It's perfect for spotting calcium and checking for any coronary involvement. Simple as that.
And PET-CT, this one's your secret weapon. You pull this out when you're hunting for infection and malignancy.
So here are your 3 commands. Know the borders, check the enhancement, and name the mass. Let's go!
Okay, stop. We're going to make a complete shift in tone here. Before we proceed, we must address our mandatory international medical disclaimer. Listen carefully. This content is for educational purposes for international boards only. It is not medical advice. Always consult official guidelines and a specialist physician for clinical decisions.
All right, now for this next section, absolute precision is non-negotiable. This is for your exams and, more importantly, for your diagnostic thinking. We're going through this verbatim.
So imagine this. A patient has a mass found incidentally on a routine exam. The very next step is imaging. Sarah, why is echocardiography, specifically TE, the gatekeeper of cardiac oncology?
It's all about its temporal resolution, Dr. Collins. The transthoracic echo serves as the quick screen, but it's the transesophageal echo that gives us those crucial high-definition views of the atria and valves. It tells us if the mass is mobile, if it's obstructing flow, or if it's attached by a stalk, just like those myxomas we covered in Module 1. But echo does have a major weakness. It can't tell you what the mass is made of.
Exactly. So echo shows us the shadow, but it's the cardiac MRI that shows us the soul. So Sarah, why is MRI considered the gold standard for tissue characterization? It's the signal intensity, Dr. Collins. By using different sequences like T1 and T2 weighting, we can identify fat, which glows on T1, or fluid, which glows on T2. But the real high-yield board fact is LGE, Late Gadolinium Enhancement.
It's pretty straightforward. If a mass enhances, it has a blood supply, which points directly toward a tumor. If it doesn't enhance, it's most likely a thrombus. For something like angiosarcoma, we'd expect to see diffuse, irregular enhancement because it's just so vascular and invasive.
Outstanding. LGE is the differentiator. Everyone watching, check the resources linked below this. The Braun-Wald section clarifies that MRI is superior for invasive versus encapsulated masses.
Okay, let's keep going. Now, Sarah, when do we call for a cardiac CT?
We call for CT when we need to see the hard stuff or the pipes, Dr. Collins. CT is the absolute champion for seeing calcification. So if you suspect a calcified myxoma or a fibroma, CT is going to show it clearly. It's also vital for surgical planning because it shows the relationship of the tumor to the coronary arteries. If that tumor is hugging the LAD, the surgeon absolutely needs to know that before they cut.
Spot on. And now for the top score question. PET-CT. When do we use metabolic imaging? We use it to find the hot spots. PET-CT is perfect for staging metastatic disease or differentiating an active infection, like an abscess and endocarditis, from a benign tumor. High glucose uptake usually means a malignant invader.
Outstanding. So the crucial point to remember is this: echo for motion, MRI for tissue, CT for calcium, and PET for metabolism.
Now we're moving into the final learning phase. This is designed for maximum retention. Sarah, let's lock in the imaging rules. Ready?
Echo,
For the motion.
MRI,
For the notion, tissue.
CT,
For the bone, calcium.
PET,
Is the zone, hot.
LGE,
Is the flow.
Links.
Review the show.
All right, well done. Now it's your turn to join the discussion. Here's our question of the day for you. Have you ever seen a case where a so-called mass on echo turned out to be just a harmless anatomical variant, like a Chiari network or a Eustachian valve? You know, those pseudotumors are the ultimate diagnostic traps. We want to hear about it. Share your imaging saves in the comments below. Excellent work today. We have mastered the fundamentals of cardiac mass imaging. To see how this all comes together, make sure you subscribe and join us for our series finale, the rapid review and tumor decision tree. See you then.